I'll just say a quick welcome. Be comfortable. We'll be fairly casual this evening. We're excited to do to hear the presentations tonight, and I'm going to introduce our speakers in a few minutes. Before that, because I'm not techie at all, we're going to turn it over to our technical people just to give us a little bit of a brief overview of how to manage the platform.
Awesome. Thank you so much, Pam. So just a really quick overview for everyone who is joined from home, some of the functionality of the Zoom webinar platform. Before we get started, we do have a couple polling questions. Those are now just activated, and so you should see a pop-out come on your screen, much like the pop-out that's come out on the slides as well. See a little delay happening, but hopefully that's up on your screen now. So there's two questions in this pre-session survey. The first one asking where you're joining from, and the second one asking which patient population you identify with or your loved one identifies with. And so you can just answer those two questions and submit them. We'll share the responses as well before we move into the content. Most importantly, you'll probably notice that as a participant in today's webinar, you cannot join by video, nor do you have the option to unmute and speak verbally. This is to help keep some of the anonymity between patients and caregivers and such, but you do have the option to submit any questions you have to our lovely panel of speakers, and you can do so by navigating to the bottom of your Zoom screen. There is a button labeled Q&A, and if you click on that, it pops out this separate window where you can then, and I'll show you really quick on this slide, where you can then type in your question here. You do have the option to submit your questions anonymously, and then you'll also see any questions that are submitted from any of the other participants that are joining tonight, and you can upvote their questions, and all that does is bring them to the top of the list and put them in order of priority for our Q&A session. So please don't hesitate to submit your questions. We'd love to hear from you, and I'm sure that our panel of speakers would love to answer any questions that you might have. So without further ado, I'm going to pass back to you, Pam, just for some quick opening remarks.
Okay, thank you. So just a minute, I need to get this out of my way here so I can see my screen. Okay. First of all, this program tonight is the fourth in a series, and it's being brought to you with a collaboration with Canadian Hemophilia Society and our local healthcare professionals. So we've done 4 across the country, and we've tried to keep it very regional, so you recognize your people there, and you're getting a real local perspective from the care that you would be receiving in your area. The content has been developed by the panel and not influenced at all by our sponsor. And just again, to make sure that we maintain a non-promotional initiative, we're going to ask you not to mention the name of any specific brands during the presentation. So when you're chatting or asking questions, if you would refrain from mentioning a specific brand, that would be much appreciated. And we are very thankful to our sponsors, Takeda Canada, for giving us the financial support to bring us all together tonight. Next slide. So it's really my pleasure to introduce the panel to you tonight. And I'm actually just subbing in tonight for your facilitator who had a conflict. So you're stuck with me, and as you all know me, I'm not very technical at all. So I'm going to do my very best, but probably many of you would know me. I'm Pam Wilton. I'm from London, Ontario. I was the president a long, long time ago of CHS. And I am a woman who has, I'm a symptomatic carrier. And I know there's people on the panel, so it's kind of fun to be with all of you. An old friend, Dr. Sue Robinson, is here. And of course, you know her as a professor of Dalhousie University and the Nova Scotia Hereditary Bleeding Disorder Clinic Director at the Health Sciences Centre in Halifax. So we're really happy to have Sue. Thanks for being here, Sue. And then we've got another Sue, Sue Van Oosten, who's the RN at your Bleeding Disorder Clinic in Halifax. Happy to have both Sues with us. And Daniel Charney is a registered psychologist. He's our guest speaker who will be speaking from a patient perspective this evening. And actually, I had the pleasure of hearing Dr. Torney speak several years ago at an event that I was at. So I know we're in really good hands. I know the topic tonight is very, very timely. I find it really exciting, and it fits well, obviously, with our hemophilia community, but it fits very, very well with the work that we're doing in chronic disease self-management, and where we're very much shifting to where patients are part of that healthcare team, and where actually you do carry a lot of the onus to help identify your goals and make decisions with your team. One more thing, and they're really going to earn their keep tonight, is our technical support from Medicom Health Inc. They've been talking us through it, working through, and test driving us here. So thanks to all of you for being here. Without further ado, I will turn it over to, oh, I'm sorry, I have to talk about the learning objectives. This is important because now's your chance. If you don't like these objectives, you can go and watch Netflix or something else. But here's our objectives for the night. We're going to do an overview of the treatment approaches for non-inhibitor hemophilia patients, hemophilia A in Canada. We want you to understand how hemophilia A management can be personalized for your unique lifestyle. And then we're going to discuss how an individual living with hemophilia can benefit from the personalized management strategy. Now I think it's over to Sue.
Okay, thanks so much, Pam. It's great to see you too. One thing about our clinic is there's two Sues. So if you are looking for someone, just ask for Sue and you'll get one of us. So I'm really pleased to be here tonight. This is a new way in hemophilia, and it's very exciting. I am pressing my button.
Dr. Robinson, I think you need to find that mouse on that screen again and take control.
There.
One more time. Oh, she doesn't want to go for you. I can help move those forward for you, no problem.
Okay. I'm also not very technology savvy, so sorry about that. So just a brief overview of hemophilia A. The normal level for factor VIII is 50 to 150%. For those of you that see your levels from the lab, the way the lab reports it is 0.50 units per mil, and that would be up to 1.50 per mil. For a patient with mild hemophilia A, the levels are anywhere from 5 to 40%. In this group, bleeds are uncommon, but certainly with major trauma or surgery, there can be bleeding. And occasionally these patients are not identified till they're older, and sometimes it's actually the symptomatic carrier in the family that presents first, and then we find out that there's some males in the family that are affected. Moderate hemophilia is 1 to 5%. They have a higher risk of bleeding, and occasionally spontaneous bleeding, but more often it is with trauma or surgery. For severe hemophilia, that's less than 1%. And typically they do bleed and have spontaneous bleeding. And usually the most common sites of bleeding are the joints or muscle bleeding. And just over here is just a diagram showing the normal range, the mild, the moderate, and severe range with hemophilia severity. Next. So looking at the factor level and bleeding risk, over on the left, on this graph, there's the factor VIII level in the bottom and the annual number of joint bleeds on the vertical. And you can see between 0 and 1, so this would be the group that have severe hemophilia. They have the highest number of joint bleeds annually. And then when you you can see over 1%, there's quite a drop in the number of joint bleeds annually, and that's in the moderate hemophilia range. And then you can see even some of the milds can have bleeds, and they tend to occur more with the lower levels of factor VIII. And then even out here with very good levels of factor VIII, there is that possibility of a joint bleed. So over on the right is looking at the annual probability of 0 bleeds by time. So on the bottom, this is the time that you would have a factor VIII level below the level of 1% or 1 unit per deciliter. So it's how many hours per week is the time vector down here. And on the vertical is, you got to get your head around this, it's the probability of no bleeds per year. So the best scenario is that you'd have 100% no bleeds, you'd be up here. So if there's no time at all that you're less than 1%, that correlates with pretty well 100% no bleeds. The top line is the younger children. This is age 1 to 6, and there's a better correlation with bleeding risk and higher factor VIII levels. This is the older group. This is ages 10 to 65 on the lower line. But you can see that the more time you have above the 1%, the less likely you're going to have 0 bleeds. So the goal for hemophilia is 0 bleeds. So we do know that a single bleed may be life-threatening, may contribute to permanent joint disease. So although the risk of intracranial hemorrhage is very low, it is possible. We would definitely want to prevent this and want to prevent the bleeding into joints that causes long-term arthritis or arthropathy. So tailoring prophylaxis to 0 bleeds is key to enhancing the joint health and improving quality of life and outcomes. And there's a number of publications that study this. And this is a diagram that was come up with, was developed by a number of hematologists, and they got together and they're all experts from around the world, and they gave their best estimate of what levels of factor VIII you would need for different activities. So up here on the left is the normal level, that's 50 to 100. So if we have a hemophiliac going for surgery, this is the sort of level that we aim for. 30 to 50% would be the post-operative level that we would aim for. 15 to 30%, the consensus was this is the level you would want for pretty intensive sporting activities. This was the boarding, 5 to 15 for high intensity physical activity, 3 to 5% for mild physical activity, and then 1 to 3% for sedentary activity when you could have some spontaneous bleeds. And just to mention about that is that obviously with those in that diagram, if you were out biking and weren't wearing a helmet, which you should be, certainly you would want much higher levels than 3 to 5%. And certainly boarding, you may well want higher levels. So this was just a guess at what levels you need for different activity levels. So this is looking at factor VIII PK profile. So the PK stands for pharmacokinetics, and this is the study of the movement of factor VIII in the blood from the minute that it's infused with the factor VIII concentrate to the time that the factor VIII leaves the bloodstream. And that would be when the factor VIII is activated and stops bleeding. And also there are molecules on the liver cells that mop up factor VIII and take it out of circulation. So the PK profile is highly variable across patients and requires an individualized approach to prophylaxis. So this diagram, this was published a number of years ago, and it is looking at over 2,000 samples from patients with hemophilia. And over on the left, they were infused with factor VIII. And then this is the time after the infusion. And then on the vertical is the factor VIII level. So as soon as and this was from, I believe it was 3 different studies. As soon as the patients are infused and they draw a factor VIII level, this would be this group here. And you can see by 6 hours, a number of patients have dropped off their factor level quite dramatically. And then over here at 24 hours, there's still patients that have a significant amount of factor VIII in the circulation. And over at 48 hours, there's still some that have quite reasonable levels of factor VIII in their bloodstream. There is a term that we call T1/2. So that's the time for the original concentration of factor VIII that's infused to go down to 50%. And usually for factor VIII, the regular standard half-life products, that's in the range of 8 to 12 hours. But you can see the big variation in individuals, that it's going to be very short and it can be very long. So the one-size-fits-all approach to prophylaxis is not ideal, potentially leading to over-treatment in some individuals and under-treatment in others. Next. So going on to this, going from the one-size-fits-all approach, moving forward to where we are today with a personalized approach. The one-size-fits-all goes back to prophylaxis that was first studied in Sweden in the 1950s, and it showed that there was a definite effect. If you were able to keep the factor VIII level above 1%, there was a big difference in the bleeding rate. And then in the early 90s was the first large publication to show that the group that was on prophylaxis and kept their factor VIII level above 1 versus the group that was on demand, the group with prophylaxis definitely had better joints. So in those days, using the one-size-fits-all approach for prophylaxis, pretty well everyone was on a standard approach. Usually 2 or 3 times a week they would infuse. And then we expected them to accommodate their lifestyle and their activity choices so they wouldn't bleed. So we were sort of encouraging them to be quite quiet and not do a lot of activities. But moving forward to where we are today, ideally the individual will know what goal they want in life. They would know what kind of lifestyle they want, what kind of activities they want to do. And then as the health treaters, we would try to tailor or help work with you to tailor your factor VIII treatment prophylaxis to accommodate that. Next. And personalized prophylaxis, it requires a multifaceted approach. So here, every patient is unique. PK study for every person is different. And it does depend on a number of factors in terms of deciding what dose of prophylaxis you should use and how frequently you should use prophylaxis. So age and weight are important. Our dosing is usually weight-based. The higher the weight, that would be harder on the joints. The older a person is, the more likely they may have joint disease, and they may be at higher risk of bleeding into those joints. Genetics is a determinant, how often someone bleeds, it is different. You can have 10 patients with severe hemophilia A, and their bleeding rate would be different. Their joint status, you tend to bleed more into joints that already have some arthritis or hemarthropathy. Adherence, if you don't want to take needles and don't want to infuse, that we need to consider that when it comes to prophylaxis. As mentioned, you need to know what you want to do for activity and lifestyle, what your goals are. And then we need to do the lab testing to know what your individual PK profile is. Next. So number one, step one, you need to set individual goals. So these are just examples going through different age groups of what you might make as your goal. Being protected while playing sports, being able to complete tasks at work safely, walking with my wife after work, not missing school or work, prophylaxis with less infusions per week, join the high school basketball team, playing golf once a week, be confident and worry-free at work, complete home renovations on my own, enjoy my time on weekends and holidays with friends. So the role of the comprehensive care team, there is at least one bleeding disorder clinic in every province. And there's the physician, the nurse, the blood bank staff, data entry associate, physiotherapist, administrative associate. There's often learners, whether they're doctors, nurses, physios, and then social worker. Depending on the clinic, you may be very rich with these resources. I would consider our poor little hemophilia clinic in Nova Scotia to be not so rich, but we do have access to all these people, and they're all wonderful. Next. So just a couple of scenarios. So this is an 18-year-old male, severe hemophilia A, recently started university and has been on 3 times a week prophylaxis with standard half-life factor VIII product. Minimal breakthrough bleeding over the previous years, doesn't have any target joints. And this summer, he decided to reduce to twice a week. He likes this better. He wants to keep to this schedule. And right now it's Mondays and Thursdays. He likes the product he's been on. He's been on the same product for a while. He does not want to consider a long-acting half-life product. He's joined the basketball team at university, and he plays Sunday nights. So something might ring a bell there with everybody at that point. He starts to get some ankle bleeds during the games and has a few spontaneous joint bleeds during the week. So this is the lab results that we had on file. So he gives himself a dose of 2,000 units for prophylaxis, and he takes his infusions Mondays and Thursdays. So the time between Mondays and Thursdays is 3 days, 72 hours. So at one point we checked his level of factor VIII immediately after he infused, and it was close to 100%. It was 90% or 0.9 units per mil. And then we checked his level just before his infusion on Thursday. So 72 hours later, and he still has a registered amount, 1.2%. So that fits with the original one fits all for prophylaxis. So then if you look at what happens to him from Thursday to Monday, again, 2,000 units, but this is a longer time, 96 hours. So he gets the same peak and when we check him right after infusion on Thursday. But on Monday morning before he infuses, he has undetectable factor VIII. And you might remember that he's playing basketball on Sunday night. So the first thing would be to go over with him that he should change his days and infuse ideally as close to that basketball practice or game as he can. and he still wants to stick with the 2 days. So he's convinced that if he just ups his dose, he's going to be better off. So we did do some levels, and there he ups his dose to 3,000 units and checks from Thursday to Monday to see if we can get a better level during that time. And he gets a higher boost, which you expect right after he infuses, but lo and behold, at the end, he's back down to an undetectable level. So he still isn't convinced. He tries 4,000 units and again, down to undetectable levels. So hopefully we convinced him that just upping the dose isn't going to do it. Based on his half-life, his PK information, if he wants to be more than 1%, he is going to have to infuse more than those 2 times a week, or he's going to have to consider long acting. Next. So this second fellow, 22, a severe hemophilia A, and he was on 3 times a week prophylaxis all through childhood and adolescence. When he moved to on demand during the transition to adults, we often see that with independence. And he felt that he really didn't need it. He was sitting in his class most of the time, and he still had minimal bleeding issues, no target joints. And with his schoolwork, he started to need to go out into the community and do some practicums, and he would take his factor beforehand. So he started back at sort of an anticipatory prophylaxis on those days that he was training in the field. He just finished his diploma in land surveillance, and he got a job as a surveyor. And this was going to involve a lot of moderate activity during the day, no longer sitting at the desk all the time. He was concerned about situations where terrain may be less stable. He was asking about the best way to stay protected to ensure he didn't miss work due to injury. So just looking at the next one. So we did his level. So he also takes 2,000 units prophylaxis, and that's his baseline level on the day that we tested him. And then 2 hours after his infusion, he went up to 66% or 0.66 units per mil. And 2 days later, we did his level and he's undetectable 2 days later. He was very interested in long acting factor VIII product. So again, 2,000 units, he gets a similar boost right after he infuses. And 2 days later, he's got 3% or 0.03 units per mil. And so I am working with him to try to take his product every 2 days, ideally, and at least every 3 days. So I'll stop there. I don't know if there's any questions at this point.
Yeah, there are a couple of questions for you, Sue. Thank you for that. So the first question that we have for you is, how can caregivers assist with personalized care management?
Sorry, could you say that again?
How can caregivers assist with personalized care management?
Yeah, well, I think if they come to the appointment and get to understand PK, and Sue's going to explain more in the next section, but just understand it. It does take a little bit to get your head around it. So I think first is just understanding, look at the data. You might help the person who is affected with hemophilia to identify their goals. They may have been used to up to now saying, I can't do this, I can't do that because I have hemophilia, but to try to see if there are things they want to do, and then work with the team and help them with what we come up with as a recommended prophylactic schedule.
And that's going to be especially important as parents, right? So, maybe helping to articulate the goals and also helping to give some of the examples and information back to the team. And of course, parents are going to be responsible for doing the recording of the bleeding and those kinds of things with the younger children. But it would be important to include them, I would think. Another good question that we've got here, but I'm going to ask one just ahead of it, because I'm interested to know, so would it be possible for everybody in Atlantic provinces to be able to access a PK study? And then the second part of from our audience here is, when should I be getting a PK? So two-part question.
Right. So right now, and at our adult hospital, we're just about to have this WAPPS that Sue will talk about. But we do bring patients into our medical day unit to get levels. And usually we get the 3 levels, early post and later post, to give them an idea of where they are. So I'm not sure about Prince Edward Island patients usually come to Moncton or to Halifax. And I'm not sure, maybe there's someone that could throw in a chat what's available in those other clinics.
Okay, and then in the meantime, the question is, are most treating physicians comfortable with initiating this kind of an approach?
I think so. I mean, it is new, and but we've had lots of education sessions over the last couple of years. We're learning more and more about it. One of the world champions is Dr. Oreo in Hamilton in Canada, and he is amazing in teaching us how to use this.
As I said earlier, it really does fit with what we're doing in medicine in other areas as well. And I think physicians are more used to how can we personalize the care so it makes sense for our individual patients. So I think it's a movement generally. So I think people will become more comfortable with it. But also, it really means for us as patients that we have to be willing to give the feedback and fill out diaries and pay attention to what's going on, so that we've got data to back up the science, so we understand better how to do this. I think we have time for one more question here for you, Sue, and then we'll move on.
Okay.
So this question says, I always thought long-acting factors stayed in the system longer than 48 hours. But looking at the data from your patient, that was a surveyor. Not sure, that might be misworded there, but anyway, thought that it stayed in the system longer than 48 hours.
Right. So again, everyone's different. So I think you would need to do the individual study to get the levels done to see how long the long acting is going to stay in the system. In most cases, the long acting does stay in the system longer than a standard half-life. That's not true every single time. But in most cases, the long-acting factor VIII products may give a day, maybe an extra day that you could go without prophylaxis. You might be able to go from 3 times a week to twice a week, but it's there isn't as big a difference as we see in hemophilia B.
Okay, thanks a lot, Dr. Robinson. That was really informative. We're going to move on to hear Sue Van Oosten give her presentation. We'll do the same thing. We'll take more questions when Sue is finished with her talk. Take it away, Sue.
Okay. Do I have control of these slides? No?
I passed it to you, Sue. You just need to find your mouse and click on that slide to take that control.
On this slide? Okay. Okay, so I want to, click on this slide.
Yep, it shows you're controlling it. You'll just have to click one more time. There you
go. Okay, sorry. Before we get started, I just want, my disclosures are just that I have been doing some work for Takeda, Novo Nordisk, and Roche over this time of COVID, as they are all doing some tremendous webinars for everybody. But when I was asked to do this, I was a little hesitant, only because although we really have been following the principles of this for quite a while, it's becoming much more detailed. So what I'm going to do is pretty much elaborate on what Dr. Robinson has said and get a little bit more into how we are doing the curves and demonstrating the curves of personalized prophylaxis. So personalized medicine is basically customized treatment, although it's the same medical care that you've always received. It's not changing the medical care, it's just making it individual to each patient. We're still using traditional approaches to understanding disease and the hemophilia process, but we're getting even better at making it personal for each patient. So as Dr. Robinson said, the one-size-fits-all approach is becoming a little bit passé, and we're trying to change it up so that we can look at each patient individually and help them to customize their approach of treatment for themselves and their lifestyle. So the goals of personalized medicine is to discover the optimal therapy and reduce the trial and error part. For a long time, that's all it was about, is we would try something. If it worked, great. If it didn't, we'd try something else. But this is helping to really pinpoint what works the best. So it's allowing for safer and better dosing options and tailoring to them to the individual. We have that the data has already shown that this increases patient adherence. And patient adherence is a challenge, especially at that time where they're moving from the pediatric center into the adult center. As Dr. Robinson had demonstrated, we get many, many patients who they come over to us and they decide they don't need prophylaxis anymore. Well, we usually prove them wrong in the long term. However, it takes some time. And if we can help them to discover what works for them the best, then that will put them in a position of understanding their own care. So then it's enabling a patient to tailor the treatment to them and not the other way around. So instead of taking a treatment and making it fit the patient, we want the patient, no, sorry, it's the other way around. Instead of taking a treatment and making the patient fit the treatment, we do it the other way around. So we want the treatment to fit, we want the patient to fit into a treatment protocol that works best for them. And unfortunately, we also have to think of the cost of healthcare, because we spend a lot of money a year on factor products. So if we can reduce that healthcare cost, that's always a benefit. So what is my role? So often one of the first things that after an appointment, Dr. Robinson and the patient and myself, we all talk about this. Then I get questions about things like, what are half-life? What's a half-life? And what's a trough level? Because we use these words all the time, but they may not mean a lot to a lot of you until we have a deeper discussion about it. And also, what are the advantages and disadvantages of a pharmacokinetic guided treatment? And it's not for every patient. We have patients out there who say, look, I'm doing great on Monday, Wednesday, Friday. I don't want to change it. And that's okay. But for others who have other goals in life, and we'll talk about that in a minute, you may want to change that up and just help them out. Another role of nursing is to coordinate the PK testing. So to get you into medical day, get the levels done, watch for the levels to come back. And then of course, Dr. Robinson and I discuss them and we try and come up with a plan. And patient monitoring. So we also will follow up with a patient, make sure they're doing okay on that plan. How is it working for you? See how much factor you're using. Are you then having a bleed and you're calling me and saying you need more factor? We don't want that to happen, because then it means that we have not come up with the best profile for you. So Dr. Robinson had this similar demonstration here. So, and went through it. But what I want to focus on though is the pharmacokinetic response. So as Dr. Robinson said, pharmacokinetics is the movement of the factor through your body, right from the time it goes in, the absorption, how it goes through the body, how it's metabolized, which means how it's used in the body, and then how it's excreted. So why is pharmacokinetics important? Because we know that if we can keep the factor VIII level above 1 to 3%, then there is a decreased incidence of joint bleeding. So the longer we can keep it above that value, the better a severe hemophiliac patient is going to do. And it can vary significantly amongst patients, even with age changes. So you could do a pharmacokinetic profile on a young child and get them on a really great program, and then they turn 18 or 19 and come over to us, and we may need to do that again because the way that the factor is metabolized in the body can change from the time they're a little child to the time they're an adult. So I love this slide. I think it's well done. So we look at this and we see two patients, and they both give an infusion of 30 international units per kilo of the same factor VIII product. So they're filling up their gas tank. But then as time goes on, one patient has a short half-life and uses up that factor VIII product in a short period of time, while the other takes a longer time period. And so to expand on that question about the longer acting products, yes, they should last longer, but if you are a patient that has a short half-life of a product, it may not last you as long as somebody that has a longer half-life. So in addition to the pharmacokinetics, we look at the trough levels depending on the individual's needs. So what is their lifestyle like? We look at the experts' consensus on different guidelines, because there's so much research being done on this that it's not just one thing that we can look at. We can't just look at the patient's lifestyle. We also have to look at the guidelines. We have to look at moderate hemophilia A patients, because sometimes they bleed as much as a severe, depending on the genetics and the bleeding phenotype that they are. They may bleed just as significantly as somebody with severe hemophilia. And so some patients on prophylaxis, even with a factor VIII level of a little bit above 1%, they may still bleed. So we have to look at them and decide what is that mark where they do the best. So where can we drop that level enough that it still stops them from bleeding, but it's not overdosing them, keeping them as higher than they need to be. So this is what a PK curve looks like. And at the top, as Dr. Robinson described, we get a peak level. So when the levels are done, the peak level can be put on a graph, and then the trough level, which is the level right before the next dose, that's called the trough level. And so it's graphed, and they come up with a curve that looks a bit like this. And as Dr. Robinson had said, the curve, depending on the activity of the patient and the lifestyle needs, the level that is required can be different. So if you're a walker, you might be okay with 2 or 3%, or a biker or a soccer player. A skier, we want to go for the big levels. Skiing, and some young men still like to play hockey, that sort of thing. We want to see the higher levels. So PK dosing is a individual curve, and it can result in very, very precise factor VIII dosing. And I'll show you how here. So there are 2 PK apps that are available. One is called PK Fit, and it's very effective, but it only addresses some of the factor VIII products. It's not used for all of them. But there's now one called WAPPS-HEMO, and WAPPS stands for, because I had to look it up today, Web Accessible Population Pharmacokinetics Service. So that's a big mouthful, but it is a global app. It is used worldwide. And we are just on the cusp of getting it accepted at our hospital. It is used at some hospitals across Canada already, but it does require it to go through some processes at the institutions in order to have it accepted. So we're hoping very soon. We got word today that it could be sooner than we thought. So that's excellent. And it is an app. And what we do is your pharmacokinetics can be entered into that app. And we'll just show you in a second how we can do this. There's two ways to do a PK assessment. So if you are on prophylaxis and you come into our clinic, you can bring a dose. If you haven't had a dose for 2 or 3 days, we don't ask for a washout period anymore, because that was at a time where we wanted you to have 0 coming in, and then we would start from scratch. But if you are due for an infusion on the day that you are to come into clinic, then you can bring your dose with you, and we can you can infuse your dose, and then an hour or 2 later, you can have a level done, and then 24 to 72 hours later, have a second level done. All it takes is the trough, you have to do a trough level before you take it, then 3 hours, and then 48 to 72 hours. There was a time when, in order to create a pharmacokinetic curve, we needed up to 11 blood samples to make that curve. But now we can do that curve with 3 using the WAPPS program. The other way to do it is if you have given your product 2 days or 3 days prior to coming to clinic, then we can do that sample as soon as you get to clinic, and then immediately, then you infuse as soon as you get to clinic, and then you take the blood sample a few hours later at the 3-hour mark. So then we have again, we can have 3 blood samples that we can use to put on that curve. So there's different ways that we can do it so that it accommodates the patient that's coming in for their clinic visit. The good thing about the WAPPS app is it is connected to MyCBDR. So it will not mean that the data has to be put in twice. It will be put in once into apps, and then it will connect into the MyCBDR app. And with PK Fit, it would have to be manually put in outside of your MyCBDR, because those two don't connect. But fortunately, MyCBDR and my WAPPS do connect. So the advantage to the mobile app is that it can help you predict where your level is at a certain time. So if you've put in your pharmacokinetic profile and you want to know, for example, I'm going golfing tomorrow, where will my factor VIII level be tomorrow at 10 o'clock when I'm going golfing? You can put that into the apps, either one of these apps, and it will estimate for you where your level will be. So it personalizes for you. Then if you think, oh, well, I'm not going to have quite enough factor VIII to do my activity, you can then adjust your doses a little bit to make sure that you are covered to do that activity. Okay, so here's a case study, and I hope I don't lose you on this because it's a little bit more detailed than perhaps Dr. Robinson's was using the WAPPS app. So this is a 21-year-old male with severe hemophilia A. He has a missense mutation and was diagnosed at birth because of a family history. His pre-COVID activity involved very active sports, but he's currently working from home, and his physical activity only includes now walks and biking. His weight is 75 kilos and he is 175 centimeters tall. He does have some, his right ankle is affected, having had bleeds in the past. So he has a target joint of that right ankle, but he has no history of a factor VIII inhibitor, which is an antibody. and he has great venous access. And we always have to consider that when we're dealing with home infusers. So his patient goal is that because he's not doing his sports, he's not playing hockey like he would normally, then he would like to limit. He still wants to stay above his baseline factor level to keep himself protected, but he wants less needles. He wants less infusions. He's tired of this and he wants less infusions for now anyways. So we have to consider on WAPPS-HEMO all of the different factors, including his bleeding history, the fact that he has an ankle, his lifestyle is now less active. He has had no inhibitor, but he does want a PK profile. So he's on extended half-life of 2,000 units on Monday, Wednesday, and Friday. So we look at first his 2,000 units from Monday to Wednesday, and we see that with his 2,000 units, he gets a peak level of 0.7, which I had them put in brackets as 70%, because that makes it more familiar to those of you who are giving infusions. And before his next dose, 2 days later, he's around 10.6%, which isn't bad. But then, so then his Wednesday, Friday, again, he gets up to about 76%, and his trough level is 11.5. Again, not bad at all. Then on the Friday to Monday, he's 77%, but he goes down to 5.1, which still is not bad. But this fellow doesn't want 3 needles a week anymore. He would like to decrease his number of needles. But if you look over here, we always consider this as well. In a week, he's giving 6,000 units. 100% of the time, he's above 1%. 100% of the time, he's above 3%. And by graphing it on here, dropping on the graph, you can also calculate that 70% of the time, he's above 15%, which is really quite excellent. But again, he doesn't want 3 needles a week. So we try something else. We do a twice a week. So we do a 4-day, Monday to Friday. He gets a nice peak of almost 70%. And his trough is 2.2, which is still above the 1% level that we always are making sure that the patients are above. But then his 3-day, he gets up to the nice 70% almost, and he's 4.4%. So by using 4,000 units in a week, he's still above 100, or he's still above 1% all of the time. He's above 3%, 94% of the time, and he's above 15%, 44% of the time. That's still very, very acceptable. So then we try him 2,000 units every 3 days. So he gets his 70%, and then 3 days later, he's at 4.6. Again, very, very good statistics over here, but using more factor product. We try every 4 days, but on 3,000. And like Dr. Robinson demonstrated, by changing him from 2,000 to 3,000 every 4 days, the difference is negligible. So he gets a nice peak of 100%, but he drops back at 4 days to 2.1%. And on 2,000, he gets a very reasonable peak at almost 70%, but drops back to 2.1%, which is statistically or comparatively almost the same. But if you look over here, he's using 5,250 units a week by using 3,000 on only 3,500 a week by using 3,500. So this fellow decided actually that he wanted to go on every 4 days, but was happy by looking at these PK values that he could do it with 2,000 units a week, 2,000 units a dose every 4 days, still covering himself above 1%, 100% of the time, above 3%, 87% of the time, and above 15%, 38% of the time. Okay. So World Federation of Hemophilia guidelines released this year two main points. One was that early intervention before the age of 3, prophylaxis should be started to prevent bleeds and extensive joint disease. Unfortunately, we still have a very large percentage of our world, up to 75% of the world, is still not able to comply with that simply because of the lack of factor product. And also they have come out this year with prophylaxis as being standard of care, and it should be individualized based on pharmacokinetics. So that's why Canada has really tried to adopt this way of individualizing care for all those of you who are on prophylaxis. And I believe, oh, that's the end of mine. So I guess if there's any questions, or a couple of questions.
For you, Suveno, and so I've got a few coming up here on our question and answer. So I think you've answered this, Sue, but the question says, how do I know if I would be a good candidate? Does this work for everyone? And so this question actually popped up when Dr. Robinson was talking. So could you just briefly review that for us, Sue?
Well, I think the best way to answer that is to say that we can try it for everybody. If you're interested in it, it is generally used for those who are on prophylaxis. And there, we would like to be able to say that someday we have pharmacokinetics on everybody on prophylaxis, because it's very, very helpful. We also do it as well on some of our milds when they have surgery. We take pre and post levels as well to try and see how they metabolize factor. But I think to know whether you're appropriate, you just need to talk to us, ask us, think about what your goal is, why you want to have it done, and what the goal for personalizing it would be. And certainly we can discuss it and decide if it's appropriate for you.
Okay, and Sue, do you know, now you mentioned that your hospital is just in the approval process of the WAPPS app, but how would, the question is how would we access these apps?
Okay, so once it's approved by our hospital, we have a fellow named Chris, who many of you know, who does a lot of the My CBDR stuff. And he is going to assist us with getting it all linked up with the help of Hamilton, where Dr. Iorio helps with it. But it will be something that once we have it approved by the hospital, it will become available for those who are on My CBDR and who would like to use it.
Okay, I'm going to skip down to question because this is related. Have you had, well, you aren't doing this yet, so the question is a little bit unfair for you, but one of the patients is saying that he's having difficulty connecting My CBDR and my WAPPS, and so he has to enter the information twice. And maybe I'll just throw that out. Maybe you could do that in the chat, because maybe some of those using those apps would be able to answer that for you. And if not, maybe we'll bring it up again later when we do the general questions.
Well, the only thing I can say to that is that the main place for connecting with CBDR and WAPPS is in Hamilton through the group there. And I'm sure that I could get whoever it is that's asking the question a contact to get them having it work, like getting it working better than they are, because there are technical people out there that certainly do help with that.
Perfect, thank you. And then a question here is, will my PK be the same for all products?
No. That's why when we go from one product to the next, you have to come back in and have another PK done to make sure that we're getting it correct. So some of you might remember that when we changed products in the last tender, we asked you to come back into medical day and have a new PK done. And that's to ensure that we're getting the right levels at the right times for the product that we are now using with you.
And I have one last question here, and we've got time for it. Does personalized therapy allow for all physical activities?
Well, I guess that sort of remains to be seen, and that's something you have to discuss with your healthcare provider. I don't know that you're ever going to find a healthcare provider of hemophilia saying, "Oh yes, it's great to go and play contact hockey." But I also think that we have to be realistic and know that there are going to be young men and women out there who choose to do that anyway. So we would rather work with you to come up with a personalized care plan and pharmacokinetics and help you be able to participate in those sort of activities rather than saying, no, you can't, because we know that there are always going to be those who are going to try and do it anyways.
Well spoken by a wise nurse. Thank you. I think, well, there's just, you know what, there's another question here, but I've got a feeling that Daniel is going to answer that question as we move along through his presentation. And then we're going to have questions and answers at the end more generally. So let's keep that one on our list and we'll move along and we'll let Daniel take over. Thanks, Daniel.
Yeah, no problem. So I think the first question that I was told about was what personalization means to me in terms of treatment. So I'm a mild hemophiliac, and we joke in the clinic that I've probably been in denial about for most of my life. I have never really liked to get treatment, and I was on PRN for many years once I finally started getting treatment. But personalization started for me a couple of years ago. Going into the hospital to get care from Dr. Robinson and Sue was great, but it was resulting in a lot of impairments. So time off work, time away from activities, just a lot of challenges to go in and get that care. So what happened was we started on prophylaxis, and initially we were on once a week, sort of every Friday schedule. And I think I started personalizing under the table. I didn't really tell them that I was doing that at the beginning. I started adjusting my adherence, I call it, to using product, based on my activity levels. So watching the slides tonight, that made a lot of sense. My day was Friday because typically what I told Dr. Robinson and Sue, I said, weekends are busy. But some weekends I would do nothing. I would just stay home, watch Netflix, hang out. So it made not a lot of sense to me to be using product on a Friday when I was just watching TV versus other days, so my activity as I get older is golf. If I was golfing on a Thursday, it would make sense to use my product on a Thursday and then go out. So I started doing that. I adjusted on my own. And then it turns out that was a good idea. So yeah, that's been my personalization experience, and it's certainly cut down my visits. I don't count anymore how often I go in, but other than my annual sort of checkup at the clinic, I don't think I've been in quite a few years. So yeah, that's been my experience so far.
Okay, so I think you've kind of answered this a little bit. And you talked about working with your physician and your nurse to get their expertise in helping you to define what you were going to do. How important was it that you be part of that discussion as opposed to both Sue's there just figuring it out and telling you what to do? Speak from your psychology point of view on that one, please.
Yeah, no, that's a good question. So, whether it's medical model or mental health, treatment adherence is a huge issue. I used to I still do hate needles. And Sue Van Oosten can attest to this. There was a long, unfortunate period where I would actually pass out and faint during my treatment at the clinic. It became sort of a running joke that the anxiety guy can't handle needles. They would have fans going and cold towels and lazy boy chairs. It was kind of ridiculous. So treatment adherence was not easy. And Sue helped me get over my fear of needles, got me to a place of self-infusion, which I still sometimes can't believe that I do. But I think that helped a lot in terms of adherence. So when you personalize healthcare and you own it a bit more, you're much more likely to be adherent to that sort of medical treatment procedure or regimen, rather than being prescribed something. And really that's no different in my line of work. You know, I can tell someone, go do this, you know, do these exercises, these relaxation, whatever it is. If the person doesn't own it a little bit, if it's not personalized to their needs, they're much less likely to carry out that treatment plan. So I'm a little bit of an anomaly. I'm pretty adherent to most treatment plans. I just recently did some physio through the hematology clinic, and you know, she says stretch, and I say for how long. But I know a lot of patients aren't that adherent, and I think that personalization, it just makes more sense that you're doing it when you need it versus just some pre-prescribed schedule, whether it's a physician or a nurse.
And so then understanding some of the challenges that you went through, you described, you know, being afraid of needles. So many people are afraid of needles. It's for some people, it's worse than snakes. So frightened by that. So of course, that had a profound effect on your ability to want to adhere. But as you went through some of those challenges, and you've already spoken a bit of the benefits, what would your advice be to people who are just thinking, hey, this sounds really good? What would you advise the people on the call tonight to help them get through that transition?
Yeah, I mean, you know, I talk about this a lot with folks who are afraid of needles. You know, no one, well, I'm yet to meet someone who enjoys infusing. So, I mean, you know, when Sue was giving the example of the individual who wanted less needles per week prophylaxis, I mean, this is a great way to do that. So again, in my case, I'm a mild, but sometimes in the clinic, we talk about how I can bleed occasionally like a moderate. And so this has reduced my overall level of bleeds and exposure to needles. Because if I'm smart about how I use my personalization, so if I say I'm going to go on a golf trip to Cape Breton, I'm going to play 36 holes in 24 hours. It's going to be really hard on my elbows, which are my joints, target joints. I know that I need to infuse, you know, first thing that morning before the 9 hours of golf. Versus infusing, you know, 3 days later, which it's already too late. I've already had the bleed or the exposure to that damage to my elbows. So to me, it's a no-brainer. I don't really even understand any objections to this kind of approach, because to me, I really do see all benefit and very few drawbacks, other than if the individual isn't good about keeping on top of things. You do have to obviously have a little bit of organizational skills. And, you know, there can be a tendency, and I'm guilty of this, if I have 2 or 3 weeks where I feel really healthy, I might not infuse. And I know that I'll occasionally get a talking to from my treatment team that I should still be infusing on a prophylaxis basis. But you know what, if I feel really good and I kind of know in my head and my body I don't need it, I don't. And I feel good about that, because for me anyways, from a patient perspective, you know, I don't want to say forget, but I can put my hemophilia aside for a week or two and kind of pretend like, yeah, I'm just like everyone else. So that's really meaningful, I think, to folks from a patient perspective, and to me another benefit.
And absolutely, Daniel, you're being truthful, right? I don't think there's a human being who's perfectly adherent to if they're on some sort of a medical routine or what, just even a health routine. And so I think when you're being honest, we're talking about real life. And I'm happy that you brought up the point that it does take work from the patient or the patient's parents, because I'm showing my fingers are about an inch apart or 2 centimeters for those of you much younger than me. you spend about that much time with your healthcare providers, and I'm going to stretch my arms out to about 5 feet and say that's the amount of time that you have to spend figuring this out yourself. So, you know, with the guidance from the clinic and with your own experience, and you put that together, I think you've got the best recipe for personalized care. So thank you for being honest and sharing it. I think at this point we are probably ready to move into the question and answer period, where we can open up the floor. And I encourage our panel here, anybody jump in who wants to answer the question. I can see some questions coming up here. Let's see. So what are the questions here? You kind of answered it when I asked it before. What are some of the challenges preventing PK testing? Suvan, oh, when you answered that a little bit before, you had a lovely slide who showed us in the old days that you came in washed out. So you didn't have factor on board, you came in fresh, had your shot, and then you stayed. But that could take a long time so we're lucky with our family, we live in the same city where our clinic is. But if you didn't live in the city over that long period of time, waiting for the testing, I could see that that might be a challenge and a barrier to people. So, you know, that you described it on the slide, but what do you think some of those other challenges might be preventing PK testing? That's coming from one of our participants.
Well, right now, one of the challenges is COVID-19, because most of our appointments are being done on the phone, simply to try and decrease the number of people within the clinic. But I'm sure that if somebody was, you know, if we get WAPPS up and running and somebody's adamant that they want to have PK testing done, I'm sure Dr. Robinson or Dr. Keating, who are both our physicians, would not be opposed to having that done. Medical Day is still open. They've been open through all of this, and it can be done. It's just a challenge because we have to kind of restrict the number of people that come through clinic as much as we can. So our phone calls are being done as our general appointment times. The other one, of course, is, as you say, they can come in and have their they can have their 3-hour post. It's that 48-hour post level at a distance that's always been a challenge, because the outside labs, there is only one place in the province that can do factor VIII testing, and that is at the QE2. So our biggest challenge is getting the blood sent from an outlying hospital to the QE2, frozen, stayed frozen, not sitting around for 4 or 5 hours and degrading before it gets to us. So it's always ideal if the patient is within the area of the hospital to have that third level done. But if not, we can always try it from a distance. But sometimes we have difficulty with that one. The other option, according to Dr. Iorio from Hamilton, is we can actually do a pre-level, a early post level, and then even a 6-hour post level. And it's, as long as we have 3 levels, we should be able to come up with that PK curve. Dr. Robinson, you may have something to add to that.
No, I think that's a really good explanation. But what you mentioned about the degrading of the factor VIII protein in the test tube is very important. There's just a couple of clotting factors that do that. So if we had someone with hemophilia B and they wanted to get their blood drawn, 5 hours away and have it sent, no problem. But for factor VIII, it's, if it, like Sue said, if the temperature isn't right, if the freezing thawing isn't right, then we get a falsely low level. So we just can't believe any levels we get outside the hospital. And even in Halifax, some of the Halifax clinics, we can't rely on them either, because they don't have a delivery person that's bringing the blood in like every half hour. So it's a very big problem, because you've got to come in, and the majority of our patients with hemophilia do not live right in Halifax. So we're, saying they've got to come a long distance and then stay this number of hours to get some testing done. So it's a problem.
I was just trying to unmute myself. So I just want to say, because I know we've got people participating from the other 3 Atlantic provinces, and it would be ditto in your provinces as well. You need those specialized hematology labs with very skilled specialized techs in there. So that can be a challenge, but it doesn't mean you shouldn't be asking and advocating for it.
That's right.
Okay.
Oh, you're muted. You're muted, Pam.
There we go.
There we go.
I bet you my husband wishes he could do that. Anyway, can prescription medications interfere or alter pharmacokinetics of factor VIII? And if so, which ones?
Ooh. Hey, Dr. Robinson, can you speak to that? Nope, you're muted.
Yeah,
There we
sorry.
go.
I'm not aware of any medications that will change your PK. You know, when it comes to drugs, we also do PK testing in various drugs, and that makes a difference often with medications. But I don't think so.
No, I can't think of any.
Okay. Another question. How can parents of a child know if there is a joint bleed? Are there any visible signs?
Ooh.
You know, if I may, I think that's kind of off topic, although it's a really, really important question. I'm not sure we could thoroughly, appropriately, and safely answer that on this call tonight. I wonder if somebody, and of course it's anonymous here, so I don't know. I wonder if we could encourage that person to be in touch with their clinic. Is that,
Yeah.
Suze? Is that okay?
Yes, I think that's ideal, because we're not pediatric. I mean, we could probably answer it having been a camp nurse or whatever, but I think, yes, it's best for them, because we're not pediatric treaters, that maybe they should talk to their clinic nurse. Absolutely.
Okay. There's another question here about needles. So this one's for Daniel. Even though you hated needles, do you feel prophylaxis improved your quality of life?
Yeah, 100%. We had a bit of a discussion with Dr. Robinson and Sue around, I was a bit hesitant because going back to, I still don't like it. But in terms of the quality of life, it's undeniable. For multiple reasons. One, like I talked about, it reduced my trips to the hospital. So as much as I adore Sue and Sue, I try to stay away from the hospital as much as possible. And that it helped, you know, with my work and my personal life. I didn't have to take time off. I can do most activities. I mean, I know better than to play hockey and things like that, but you know, even golf is hard on my target joints. Even things like long walks and other activities that I do can sometimes hurt some of my joints. And last but not least, the needle business. You know, from an anxiety perspective, the more exposure you have to something you're afraid of, the less afraid of it you become. So setting up a weekly prophylaxis schedule has reduced my anxiety towards needles, you know, I don't know, 90% it feels like. I always tell people now, I don't get anxious with needles. I get angry with needles if I miss multiple times. You know, it's frustrating. But you know, in terms of anxiety around them, you know, that's gone down significantly. I still don't like seeing my blood drawn, but that's about it. So, I mean, the answer is yes across multiple domains. My activities, time in the hospital, all of that has improved, just because I learned how to self-infuse at home on that personalized schedule. I think it still would have been fine on a regular prof schedule, but I think it's just been doubled in terms of effectiveness from a personalized, you know, adjustment kind of timetable.
Thank you. I don't see any other questions coming through there. So it's getting late. It's even later for you in the Atlantic provinces and even later for you in Newfoundland than it is for me in Ontario. So I really, really want to thank all three of our guests. I know you're very, very busy people, all of you, but I know that you all care very deeply about this community. And so it was wonderful to have you here. I always learn something, and I will speak for the participants in saying that I'm sure that they learned a lot as well that they can use to improve their lives with hemophilia, and to encourage them to open the discussion with their physicians and nurses about personalized care, and to understand and be ready to think about the responsibility that they'll take in this, but the freedom that it'll give to them and the confidence as well. And there might be some advocacy for us to be doing in CHS and chapters to make sure that you've got access or a way to have access to the testing that is appropriate. Because the last thing that we want you to do is to have inaccurate lab results, and then your docs and nurses are blindly trying to do their best for you with not having accurate data. And so it might be something we have to advocate for, to work for, as we work for a lot of things together. So again, thank you so much, and thank you to Takeda. Thank you to the people who have supported us to work through the platform and get through the work that we needed to do. And I hope that you all enjoyed it. Please keep yourself safe and well, and happy Halloween to all.